Hello and welcome to this edition of Live and Ticking. The topic of today's event is pregnancy and the heart. I'm Fearghal McKinney, head of British Heart Foundation, Northern Ireland. Pregnancy is a unique and complex physiological process that places significant demands on the cardiovascular system. In this event, we'll explore the impact of pregnancy on the heart, discussing conditions that can arise during pregnancy, such as preeclampsia or gestational diabetes. We'll also be discussing the experience of pregnancy if you have a known heart condition. Our first speaker today, Becky Shorrocks, will be sharing her story of just that. While Becky and her partner were making the decision to have a baby, Becky was diagnosed with arrhythmogenic right ventricular cardiomyopathy, or ARVC. This diagnosis then shaped her experience of pregnancy, and we're very, very grateful to have Becky here today to talk about her journey to motherhood. We'll also be joined by BHF Professor Abigail Fraser, who'll be sharing her research into adverse pregnancy and the short and long-term effects of this on the cardiovascular system. Finally, we're delighted to have with us Alicia Burnett, who is practicing midwife and advocate for Black baby loss awareness and diversity in midwifery. She'll take us through what to expect during pregnancy and how to look after your heart. You can submit questions for all our speakers throughout the webinar via the Q&A function at the bottom of your screen. We'll try to answer as many questions as possible during the Q&A. However, if we're unable to answer your question, then you can call our heart helpline and speak directly to one of our cardiac nurses. You can also join our Health Unlocked community forum for support. This forum provides a safe space to discuss living with any heart or circulatory diseases. Of course, all of our incredible research is funded 100% by you, the public. If you're inspired by what you hear today, then all donations to support our life-saving work are very much welcomed and appreciated. There's a link to donate in the chat box, should you wish to do so. Finally, before we hear from our speakers, I'd like to ask you a quick poll question that we do regularly during these events. And how would you rate your understanding of pregnancy and the heart? 1's very little and 5 is a lot. And I'll just give you a little moment to complete that survey. In the meantime, I'm delighted to introduce our first speaker today, Becky Shorrocks. Becky will be talking through her experience of becoming a mother with Ruth Huntman from the Heart Stories team here at the BHF. Ruth and Becky, over to you.
Okay. Becky, thank you so much for joining us today. It's very difficult to kind of whiz through your story in 10-15 minutes because it's so inspirational and so complex, but we're very grateful that you've joined us. So can I start by asking you to just fairly briefly tell us sort of what led up to your diagnosis, because it came out of the blue, didn't it?
It really did, yeah, and it is quite tricky to sort of sum it up briefly. So if I do go on, do stop me. But essentially, I was just about to turn 35 when I was diagnosed. I led quite an active life, living in London, running from one thing to the next. I'm an actress, so that keeps me pretty busy. But also I really loved my exercise, and I'd been doing sort of high intensity classes, boot camp, boxercise, loved all of those things and never encountered any symptoms. And then I started to train for a half marathon, and looking back on it, I think this is where the symptoms started. And I think that's because I was doing sustained exercise. But however, I did that half marathon absolutely fine, got through it, didn't experience anything. Then the following year, I'd just done a very busy panto schedule, and I started to train for another half marathon, and I encountered the symptoms again, which were I'd gone for a run in the morning, just like dizziness, breathlessness, just felt nauseous. I never did pass out. And on the day I went into hospital, I'd gone for a run, but I had an audition to get to, and I started to experience these symptoms. Decided to go to the audition because I had encountered them before, so I didn't think they were that, weird. went to the audition, came back, and I was still experiencing the symptoms. So this is quite some time later. My husband said to me, you're grey. So we rang 111 and they advised me to go to A&E. Got to A&E, and when eventually I was seen, I was rushed into resus. My heart was going at 250 beats per minute and in an irregular rhythm. So they had to shock it back into a normal rhythm, which, luckily worked. And then I was very, very lucky that they kept me in hospital for around 2 weeks. And I had, various tests and MRI. And as I say, I was lucky. I was fortunate that they were able to diagnose me within this short period. I know some people can go through months, years of not actually having an official diagnosis. So I know I was incredibly lucky that I went into hospital in that moment where I was encountering the issue.
That's brilliant. That's perfectly explained. So, I mean, all of that, and then you had an ICD fitted, and you got your diagnosis.
Yeah,
you got your diagnosis of ARVC.
I think it's just AC, and I think now it's arrhythmogenic cardiomyopathy.
Yes,
effect. So yeah,
absolutely. But of course, that's a hereditary heart disease, and so all of that was would be more than enough for anyone to process. But when you're young family, and you're young couple, and you're starting to consider having a family, it must have been devastating. What were the kind of big questions, and how difficult was it to sort of make that decision that you were going to start a family?
Yeah. The thing is, I'd always been slightly unsure anyway because of the kind of lifestyles both myself and my husband are performers. So we lead quite selfish lifestyles and, very financially unstable. So like everyone, it's always a big question. But then suddenly when you've got this, it's like, oh, wow, you really have to dig deep and ask yourself, is this what you want? And I think for my husband, a big question was, am I going to be safe? Am I going to survive pregnancy? And so that was the biggest concern for him. For me, I think I kind of became quite dramatic and was like, well, if I'm going to die, then I should leave a part of me behind. Yeah, obviously you then we were at the point, we've been married a couple of years, so we were at the point where we were about to sort of come off contraception and let's just leave it to fate, I think is where we'd got to. But the genetic counsellor advised that we wait, get your head around the condition itself, and then weigh up the pros and cons of having a child. And then we were told about PGD, the pre-implantation genetic diagnosis. So, and I think you're offered 3 rounds of it on the NHS, which is incredible. So we knew that was the option that we were going to take so that we wouldn't pass on the faulty gene at this stage. That's what we thought. We thought, yes, this is the route for us. But of course, then your pregnancy journey changes and everything changed.
Absolutely. Before we get on to that, can I just ask you, so I suppose that there's 2 major things at play here. The horrible fear that you could pass this on to your child, and also the very real risks to yourself of the strain it would put on your heart. I mean, what were you told about those risks?
Well, I knew that, it put more pressure on the heart of the pumping more blood and everything. I was told, I guess every case is assessed individually, and I was told, I think my condition isn't that or wasn't that advanced. So they believed that I was fit enough to be able to withstand the pressures. So they definitely put our minds at rest, I think, from that perspective.
Cool. As you've just touched on there, Becky, the reality of your pregnancy journey was very different to how you envisaged it at the outset. So can you briefly kind of explain, because this is quite incredible.
Yeah, so yes. So the first thing I had to do, I discovered I had cysts on my ovaries, first of all. So I had to undergo surgery to remove those to increase chances. So that was my first time under general, which was pretty grim and nerve-wracking as well, because I had to have my device turned off and all that. So it's all a lot to take in. Anyway, recovered from that and then began sort of the IVF treatment, and then went in for my egg retrieval. And unfortunately, I didn't produce many embryos, so they were only able to get 2 viable ones. And then they take them to try and fertilize them. But I think, the next day we received a call to say that they hadn't been successful. And actually, she said that she really didn't, because they were so unsuccessful, that she didn't think this was the route for us. Mm-hmm. So hearing that, I was quite upset, and actually, and in some ways that helped, because that showed me how I really felt about it. And then we kind of knew that we definitely did want a child. However, we were just going into lockdown. So we were like, we can't do anything now because I'm going to need to be so closely monitored. It's not the right time to be going in and out of hospital all the time. So we waited. And I think some point during the many lockdowns, we decided that we would perhaps start trying, and that we were okay with the possibility there's a 50-50 chance that they would inherit the gene, and even then, even if she does carry the gene, it doesn't mean that she'll develop the condition. I'm the only person in my family to have developed this condition. Anyway, I lost my dad not due to this, but to cancer at the end of lockdown, and then very shortly afterwards discovered I was pregnant. So it felt like it was kind of meant to be. Mm-hmm. So yeah, I kind of I trusted that it kind of was going to happen, because it felt like it was a gift.
yeah, that's beautiful. So kind of fast forward to the actual moment that Dot was mm-hmm. born. I mean, can you, I can't imagine, because of everything you've been through, sort of what that must feel like. So can you kind of describe the emotions that you and your husband Paul, without being too intrusive?
No, well, obviously incredible joy, immense relief because of everything you go through during the actual birth. But I mean, that's like everyone, isn't it? There's several like touch and go minutes where you think, oh God, is this gonna happen? And actually my heart behaved itself throughout the pregnancy and through the birth. So yeah, but it's all very surreal and blurry.
Yeah.
with the added drugs.
Which is a good thing. So she's had her first birthday, hasn't she?
Yeah, she's two and a half.
Two and a half. Oh my word. I know everybody says their child is perfect and beautiful, but I've seen pictures, and purely objectively, she really is. I mean, can you describe a little bit about her personality?
Oh my goodness. Well, she's very strong-willed.
Wonder where she gets that from.
She is incredibly cheeky and very funny. Now that 2 is a great age, and they're just, although they really do keep you on your toes, and I would say now is heart-wise, now is the time I'm finding the hardest, because I am getting a bit tired, and the early mornings, I can start to feel I have little arrhythmias here and there because of that. But I know when I'm fully rested, I don't have that. So I know that this will pass. But yeah, she's just joyful and entertains us on a daily basis.
Amazing. We should have actually had her on. I had little pictures up, but maybe we can post some later. As we draw to a close, Becky, can I just ask you, you've been an incredible supporter of ours for many, many years now, sharing your story in multiple ways, and thank you again for that. But can I ask you what it means to you to know that we, Professor Abigail and other researchers are researching into this topic? What kind of hope does that offer you for the future?
So much hope. I'm part of many online Facebook groups as well. There was a very specific one, pregnancy for ARVC, which was really helpful for me. But I just get to see how many women are just find these decisions so difficult. And it's just so helpful to have resources and information, and to hear other people's stories that have gone through similar things. So it's just incredibly hopeful. And I think that's something as well, so hearing about all this research that's taking place with conditions like mine, where they could potentially correct the faulty gene, that I think gave me great hope moving forward. In this way, if she does carry the gene, there is a chance that we may be able to correct that, and that's just incredible. And hopefully one day, we'll see an end to these conditions.
Brilliant. So yeah, it's perfect to end on a message of hope. But thanks again, Becky. I think there'll probably be quite a few questions, and I know everyone will have found your story really inspirational. So thanks so much again.
A pleasure.
And can I echo Ruth's thanks, Becky? We really appreciate you sharing your story with us today. And thank you too, Ruth. Our next speaker is BHF Professor Abigail Fraser, who will take us through her fascinating and important research. Welcome, Abigail.
Thank you very, very much for having me. So I'm going to be the boring academic who shares some slides as well. Hopefully you can now see those. Yeah, great. Okay. So I'm an epidemiologist. I'm not medically trained. I work with numbers and statistics and populations, but I am not a medical doctor. And over the course of my career, I've been really interested in this idea that has been gaining a lot of traction, that women's reproductive indicators, so indicators of the reproductive health from across the life course, from childhood and menarche through to menopause, actually tell us something about their cardiovascular health. And of course, I am particularly interested in pregnancy, which is the topic that we are discussing today. So as Fearghal has already said, and Becky has told us about, mum's physiological response to pregnancy is really extreme. It's really profound, in that mum prioritizes the fetus, so she becomes more insulin resistant, pushing nutrients to the growing fetus, and of course blood volume increases, heart rate increases, cardiac output increases, as you can see here in the figure. Basically, she works really, really hard to keep baby safe and growing healthily. And we also know that, and this is a very conservative estimate, that at least 1 in 3 women will experience what we can There are many terms that are used: adverse pregnancy outcomes, pregnancy complications, placental syndromes, cardiovascular diseases of pregnancy. But I'm just going to use adverse pregnancy outcomes for our talk today. And at least one in three women will experience one of these adverse pregnancy outcomes that include the hypertensive disorders of pregnancy, which are preeclampsia and gestational hypertension, which are characterized by hypertension in de novo, so discovered for the first time in onset in pregnancy, preterm birth, where a baby is delivered before completed week 37, fetal growth restriction, which I think speaks for itself, and gestational diabetes. And this table here, which is busy, and you really don't need to look at all the numbers, basically is a summary of lots and lots of studies that have now really shown consistently that adverse pregnancy outcomes are associated with approximately a twofold increase in risk of mom having a cardiovascular disease later in life. And this is a body of evidence that really is now we are well aware of, and this is accepted knowledge, and clinical guidelines even suggest incorporating obstetric history in a woman's assessment of her cardiovascular health. And what I've been interested in is a bit of a puzzle. So the question that's of interest to me, I'm interested in how diseases evolve, how they come to be, is, are these adverse pregnancy outcomes, so the preeclampsia or the preterm growth, are they causing mom's later life cardiovascular disease? Or are they simply identifying women? So we said pregnancy is like a cardiometabolic stress test, if we think about that, like that. So are these adverse pregnancy outcomes simply identifying, unmasking women who already have an increased propensity for cardiovascular disease even before pregnancy? Then they get pregnant, and because of these physiological changes, for some women, it's a bit too much. Their bodies can't cope, and they go into the morbid state of preeclampsia, for example. So these are the kind of scenarios that are possible. In the first panel here, in panel A, you can see that the blue women, the curve in blue, so these are healthy women, and the one in those in red, the women denoted in red, have a higher cardiometabolic level of cardiometabolic dysfunction that they track. So they're parallel curves. Really, what we're interested in here is that they actually start, those women who do go on in pregnancy to develop preeclampsia, they start at a worse place even before the pregnancy. In scenario B, everybody starts off at the same place, but then a woman might develop preeclampsia, and suddenly her trajectory changes, and her cardiovascular risk then increases across the life course, as opposed to, and in comparison to, women who do not develop preeclampsia or gestational diabetes or preterm birth. So this, while scenario A is suggesting that the pre-existing risk is the cause of the adverse pregnancy outcome, scenario B is saying the opposite. It's the adverse pregnancy outcome. Something happens here. It causes maybe damage to the vasculature, to the heart, to the kidneys, that then women go on and develop cardiovascular disease later in life. And just to kind of throw in another little option here, is that actually maybe healthy pregnancy has a beneficial effect on cardiovascular function, which is denoted here by this drop in cardiovascular dysfunction in normal women with with healthy pregnancies. And the dotted green line are those women who do not have a pregnancy. And so with help from the British Heart Foundation, what I and my team have been able to do is actually look at life course trajectories. So to draw these, what I'd shown you so far was kind of cartoon shape, but this is actually now modeling real data on 187,000 UK women based on a data set called the CPRD. And these women have had pregnancies, their first pregnancies registered in this national registry between 1997 and 2019. And what you can see here are each of these panels is a different cardiovascular risk factor. So systolic blood pressure, diastolic blood pressure, BMI, cholesterol, HDL or good cholesterol, and glucose. And here what we've done, I think it's easiest to understand. If you look on the x-axis, 0 is the pregnancy. So anything before 0 is our measures that we have for these women before pregnancy, and anything after are measures of these cardiovascular risk factors postpartum, post-pregnancy. And here the different lines are for women with preeclampsia, that's the very dashed line, gestational hypertension, slightly less dashed, and the normal healthy pregnancies is the solid line. And what you can see, and it's very clear here, particularly with blood pressure, is that women who do go on to develop gestational hypertension or preeclampsia have a higher blood pressure even 10 years before pregnancy. And the curves really are parallel. So very much like scenario A of that cartoon that I showed you. And the same is true for diastolic blood pressure, for BMI, slightly less so for cholesterol. It's difficult to see here. And some of these, the messiness has to do with the number of measures. Here it's a bit more difficult to see, but so this is the good cholesterol. So you can see that the normotensive women, those who did not have a hypertensive disorders, have higher levels of HDL even before pregnancy. And again, glucose is higher amongst even before pregnancy. So even up to 10 years before pregnancy, these cardiovascular risk factors are higher in women who go on to develop a hypertensive disorder of pregnancy. And this is exactly the same type of graph. So the same risk factors, except this time we've compared women with and without gestational diabetes. And you can see maybe the most interesting figure here is, of course, for glucose, because that's, you know, a really important metric or measure of how well diabetes is controlled. And that really kind of shoots up. So again, is higher in women who develop gestational diabetes before their pregnancy, but it also shoots up postpartum. So this is what, and a final set of figures that I wanted to share with you was we also counted the numbers of adverse pregnancy outcomes that women had within our data sets. So a woman might have all healthy pregnancies, so 0 adverse pregnancy outcomes. She might have a single adverse pregnancy outcome, 2 or 3 or more. And we, of course, take into account how many pregnancies a woman has had, so that we're not comparing somebody with 2 pregnancies to somebody with 4 pregnancies. And again, the curves, I mean, they really stack up, don't they? They look like they've been drawn one on top of each other with every adverse pregnancy outcome is associated with a worse systolic blood pressure, diastolic blood pressure, BMI, and so on and so forth, from before pregnancy all the way through to 15 years after pregnancy. So even the number of adverse pregnancy outcomes can be thought of as a marker of perhaps disease risk or degree of cardiovascular disease risk. And these results really tally nicely. These, again, the same type of figures. This is from a Norwegian population. And just to show you here, we, again, the cut here in the figure at age 23, that was when women that most frequently had their first child in this data set. And again, you can see that in the hypertensive disorders of pregnancy, the dashed line, again, higher levels of systolic, diastolic blood pressure, BMI, and waist circumference from pre-pregnancy up till many years post-pregnancy. But it does start before pregnancy. And do you remember I said I showed you that final figure, panel C, about potential benefit of a healthy pregnancy? So in the Hunt study, this Norwegian study, we were also able to look at the effect of parity on blood pressure and here we're comparing nulliparous women. So the dashed line is women who did not have a pregnancy, who remained childless, to women who did get pregnant, and each of these kind of cuts in the figure in the gray curve is another pregnancy. And actually you can see that blood pressure drops on average every additional pregnancy. So there is something about pregnancy. Here's the first one. The drop is the largest in the first one. It's 3 millimeters of mercury. So quite a big drop in the average systolic blood pressure from before to after a first pregnancy, with smaller drops also noted after second and third pregnancy. So at least in terms of blood pressure, there is a so-called benefit of going through a healthy pregnancy. And that might be, you know, because pregnancy is such a stress test, it's training the cardiovascular system. It's challenging it. It might also have to do with elasticity of our arteries. We know we stretch when we get pregnant and don't quite go back to how we were before. It might, the same might very much be true for our arteries, and therefore our blood pressure drops. So just a couple of small points before I finish. Another interesting question, I think, is, so does women's reproductive health have a role in cardiovascular disease risk prediction? And we've now conducted a number of studies, and actually they don't add a lot. So information on these adverse pregnancy outcomes, when you include it in risk prediction models, it doesn't change the output of those. It doesn't increase our ability to predict cardiovascular risk accurately. And there are many potential reasons for that, which I won't go into. But also to summarize, or maybe as a final point, in the United States, people have started talking in particular about the 4th trimester. So what happens after pregnancy, and how women should be when they should see, and again, these are very American terms, OBGYN, so an obstetrician or a primary care provider. These are North American terms and terminology, but very much thinking about how women should be monitored after a complicated pregnancy or a pregnancy with an adverse pregnancy outcome, whilst interestingly, only half of the UK women have had a structured postnatal check at 6 to 8 weeks between the years of 2006 and 2016. So just to say, we still have quite a lot of work to do to ensure that women with complicated pregnancies are, you know, they do get the follow-up and the support that they need after the pregnancy has ended. So thank you very, very much for bearing with me and listening.
Oh, thank you, Abigail. Now, our final speaker today, midwife, advocate and activist, Alicia Burnett. Over to you, Alicia.
Good evening. I'm really, really pleased to be here. So my name's Alicia Burnett, as I was just introduced, and I'm a registered midwife. The first thing I'd like to say is while there can be some risks and some women with heart conditions are advised against becoming pregnant, many women with long-term health conditions, including heart conditions, have healthy pregnancies and babies. The most important things are that they are aware of the risks involved in pregnancy, they seek expert advice that is personalised to them, and they receive appropriate and timely care and support. So as Professor Abigail just beautifully explained, I was absolutely riveted the whole way through both yours and Becky's sessions. There are a number of normal physiological adaptations that your body undergoes, your body and your cardiovascular system undergo as part of your body's response to pregnancy. As Professor Abigail explains, your blood volume increases by 30 to 50% and your heart rate increases. So simply put, pregnancy increases your heart's workload. And having a heart condition can affect how your body copes with pregnancy, and it may possibly make a pre-existing pregnancy heart condition worse. For this reason, the best way to have a healthy pregnancy is to talk to your heart specialist before you start getting pregnant. That's the ideal scenario. So ask your GP to refer you if you haven't seen your specialist for a long time. This will allow your doctor to answer any questions that you might have and to fully assess your condition and to review your condition and any medications that you might be taking. It's an opportunity to optimize your health prior to pregnancy. So as a midwife, I work for the pregnancy and baby charity Tommy's, and Tommy's have a planning for pregnancy app, which isn't specific to women with heart conditions, but it provides a good overview of how you can prepare yourself for pregnancy. So as I mentioned just a minute ago, preconception support and care is vital to improving your chances of a good pregnancy outcome. So as part of your preconception assessment, your doctor needs to take a look at any medications that you're taking and if you need to change the medications you take. It's important not to stop taking your medication until you've talked to your doctor. If you're planning a pregnancy and you're curious about the possible impact of any medications you're taking on the health of your baby, there's a website called BUMPS, Best Use of Medicines in Pregnancy. All midwives use this, all obstetricians use it. So it's a website that provides reliable, evidence-based, easy to read information about the impacts of any medication in pregnancy, and it's available for free and in the form of patient information leaflets. Your doctor also needs to talk you through how your condition may affect pregnancy and vice versa, and how you'll be cared for during pregnancy. And your doctor also needs to go through any examinations or tests you'll be offered to identify when your condition is most stable for you to start trying for a baby. Fantastic. The BUMPS link is now in the chat. Okay, I'm going to cover what you can expect during pregnancy. So when you become pregnant, you'll be referred to a hospital maternity unit. You can self-refer or your GP can do this. You may be able to attend a special cardiac pregnancy clinic if there is one available in your area. You can ask your GP or cardiologist for details. You should be cared for by a heart specialist, an obstetrician and a midwife. And the treatment you receive during pregnancy will be very dependent on your condition and very specific to you. You'll be monitored very closely by your doctor throughout pregnancy and when you go into labour. You can expect regular blood checks, which are a routine part of antenatal assessment, but you can also expect additional blood tests and ultrasound scans to monitor the growth of your baby. It's really important to attend all of your antenatal appointments so any cardiovascular signs and symptoms are quickly spotted and addressed. And you may be asked to take certain medications. So heart conditions increase your susceptibility to gestational diabetes, as we heard earlier. So you might have to take extra medication to, for example, control your blood glucose levels. Birth. Broadly speaking, anyone that has a heart condition that is pregnant and is going to give birth, it's recommended that you give birth in a hospital setting, specifically a high dependency area of a high dependency birthing room, which has capacity for pulse oximetry and ECG monitoring if you need it. You do have that equipment available to you. And if you're thinking of having an epidural in labour, you should also discuss this with your doctor early on, because actually having an epidural can really rapidly and significantly drop your blood pressure. Apologies if I'm racing through this. I've got a lot of notes to cover. So I'm going to talk about your baby now and the possible implications of having a heart condition on your newborn. Sometimes heart conditions that the mother has can affect their baby. So for example, they could be born premature or smaller, which is also known as intrauterine growth restriction. Or if you have a family history of congenital heart disease, your baby may be at a slightly higher risk of also inheriting the condition. Just to reassure you, many conditions with your baby's development many problems with your baby's development can be found during pregnancy. So routinely, you're offered a scan between 18 to 21 weeks, which is called the anomaly scan. And your baby is large enough for the sonographer to see your baby's structures, brain, heart, kidneys, everything. They're large enough at that point. And if you do have a congenital heart condition, you'll receive more of these scans. Lost my place in my notes now, just a second. It's really important. Being pregnant can be stressful anyway. If you have a pre-existing condition and you're pregnant, the stress can be amplified. Don't hold it in. Speak to your GP, speak to your midwife, speak to your specialist. So if you're concerned about potentially passing on a condition to your baby or any children you may have, ask them about it. Ask them what is the likelihood, what can be done, what tests are available. And the British Heart Foundation has a fantastic genetic information service that can help people with a heart condition that runs in their family. Lines are open from 9 to 5, Monday to Friday. And I'm going to finish off with postnatal care. If you have a pre-existing heart condition or one that begins in pregnancy or one that worsens during pregnancy, you might have to remain in hospital for a few days following the birth of your baby. Common reasons that women have to stay in hospital after giving birth: they want to check your baby's feeding, they want to check that you are back to normal, you're eating, you're peeing, you're pooing, you feel fine within yourselves, you've received any medication that you might need. If you have a pre-existing heart condition, they need to make sure that you're safe to go home with that baby. There's no point sending you home if you're going to come back that afternoon or that evening or the next day. And you're very likely to be given an appointment to see your cardiologist in the early postpartum period, just to check to see if there are any long-lasting effects of pregnancy on your heart condition, if pregnancy has actually made things worse. And it's very important, as Professor Abigail mentioned. I'm absolutely shocked at how few women in the UK had their 6 to 8 week checkup between. Horrified. It's really important that you attend your 6 to 8 week postnatal checkup with your GP, even if you have to be the one to instigate that yourself, because it's an opportunity to flag up any issues with yourself and with your baby. There will be 2 separate appointments, one for you, one for baby. Any worries or concerns you have, that is the time to bring it up. Thank you.
Thank you, Alicia, for that very important information. We're now going to welcome back all speakers for the Q&A portion of the event. And some of you have already done, a significant numbers actually, added in your questions. And if there's any more, please submit them in the Q&A box, and hopefully we'll have time to have them answered. And first one in, I'm going to go to Becky. Becky, what were your biggest considerations when deciding to have a baby?
Well, I guess it was, if we did pass on this gene, you know, what was life going to look like for our child? I mean, we knew though that we would be in a great position because, as we've all said, if you know about it, then you're in a better position than somebody who doesn't know about a condition. So, you know, we knew we'd be under great care like I am already, and they would keep a close eye on her. We've got her in the system immediately, so that, you know, she can be checked regularly. And I'm very lucky because I am gene positive that I can, we can go ahead with the gene testing with her when we feel it's the right time. But yeah, I guess that was the biggest consideration. Like, are we going to be overprotective if we know that she has it, or is she going to lead a normal life? But I think we came to the conclusion that, you know, she could. This condition isn't debilitating, and for me, and I think we've got enough knowledge now that we could help her to lead a normal life.
A second question for you from an anonymous attendee. So how did your partner support you through all of it?
Oh, he's been an incredible support all the way through. Just taking on a lot of more workload around the house. Normal, doing a lot more cooking and cleaning, but it was during lockdown, so we would go for walks every single day. I was doing like 10,000 steps every day, or right up to the day I gave birth, because this was my only form of exercise I could do. I could do yoga up to a certain point, but then I started to get a dodgy hip, and I also had gestational diabetes, so the walking was really key. But yeah, my husband, we just talk a great deal about everything, and I think that happened a lot in lockdown for lots of people. You know, we just talked a lot about every outcome and about the future, and yeah, it just supported me emotionally, I suppose.
Okay, thank you, Becky. One for Abigail. Now, you did touch on this, but I will just revisit it. And it's adverse pregnancy is an indicator of pre-existing heart disease risk.
Sorry, so the question was,
Do you think adverse pregnancy is an indicator of pre-existing heart disease risk?
Yes.
Yeah,
absolutely. I think that's what our results are showing. That is not to say that is a single explanation of the relationship between adverse pregnancy outcomes and later life cardiovascular disease. So it might be that the adverse pregnancy outcomes arise as a consequence of pre-existing propensity, but then go on and contribute, as I said, by causing potential, damage to the vasculature, for example. And that is exacerbated. So they're not completely mutually exclusive explanations. But yes, our data do suggest, at least from these large population studies, that women who go on to develop an adverse pregnancy outcome already have a higher level of cardiovascular risk pre-pregnancy.
Okay. This question from Tom Crawley could be for you, but Alicia, you might want to come in too. What's the one piece of advice you would give to women in the 4th trimester to keep themselves healthy in the long term?
Honestly, speaking from professional and personal experience, get moving as soon after giving birth as you can. It's fantastic for your mental health, for your mental well-being. Moving your body really does help you get out of that funk, that the sleep deprivation. You may or may not have visitors that you do or do not want. Becoming a parent to a newborn is a lot. Moving your body really does help those endorphins get flowing. You get out, you meet people. That is the best advice I can give. Get your body moving, get out there, get meeting other people, new parents. That's my best advice.
Abigail, is there any routine angiogenic biomarker testing that helps in diagnosis as well as minimizes adverse maternal outcomes for pre-eclampsia?
So I'm going to be really cautious because, as I said, I'm not a medic. But there are now tests, PLGF and SFLIT, that are used in the later part of pregnancy. So not prepartum, but during pregnancy, that are used to rule in or rule out risk of preeclampsia.
Okay. Question for Alicia. This has been so helpful, says this question. It's great to hear from a midwife directly. Just wonder how often my heart should be checked during pregnancy.
You should have like an individualized care plan. So when you liaise with your obstetrician and cardiologist, there is a routine care pathway that everybody's on, but you need extra touch-in points. So there needs to be a care plan written for you in your notes, whether they're electronic or handheld, that you know every 2 weeks, every 4 weeks, you need to have your heart checked. It needs to be written down explicitly. So if it doesn't happen, you go, by the way, I didn't have this. Can you please arrange it for me? I hope that answered the question.
Yeah, that's helpful. Sort of linked to this is another question for you. And you've touched on it, but just maybe re-emphasize, knowing there are many different heart conditions which have many different symptoms, how could I advocate for my personal situation with the midwife team throughout pregnancy and birth?
And to be honest, when you're pregnant, you will find yourself advocating for your needs a fair bit. It's an ongoing thing, and it doesn't end when you have your baby. When you become a parent, you're always going to have to advocate for yourself. Bring a notepad, bring a pen, write down any questions you have, and whenever you have a midwife appointment, obstetrician appointment, cardiologist appointment, get them to address your questions. And if your question hasn't been answered, just keep asking. You're not being pushy, you're not being aggressive. You want the best thing for yourself and for your baby. That's it. And it can be hard, so if possible, have your partner or another advocate with you. So when you're tired and you're fed up of asking the same questions and not getting the response you want, somebody else can pick up the baton and take up for you.
Okay. A specific one on tests. Are there any tests you can do if you're thinking about trying for a baby to see if you're at higher CVD risk?
Honestly, a cardiologist would be able to answer that question, or a fertility specialist. Preconception care can be hit or miss or non-existent. So that's why it's so important that you seek out preconception advice and support prior to becoming pregnant, so you can ask those things. Because once you're pregnant, a lot of your options are reduced.
Okay. Becky, just sort of aligned with that, what specialised support were you offered throughout your pregnancy and postpartum?
Yeah, well, I would say the care was brilliant that I received. Like, I never had to push for anything. It was all outlined for me. And that was even coming out of COVID, you know, as well. So I was definitely going in every 2 to 4 weeks to be seen. And my medication was increased as a precautionary measure, just to make sure. And then I was receiving echoes the whole way through to check there were no physical changes to my heart. So yes, the only time the actual birth itself was a little more chaotic, but I guess that is the same for every pregnancy. So yeah, because it doesn't feel like everyone's aware of what is going, because there's so many staff obviously at different points. So it was a little bit more chaotic then. But the actual pregnancy, I was so pleased with the support I received.
Good, good. One for you, Abigail. Conscious that you're not on the medical side, but they are directing at you. Are there any preventative measures which can be offered to mothers who go through adverse pregnancy?
I mean, all of these measures that we've looked at are the kind of stay healthy, stay fit, eat well, sleep well, don't smoke, all of those, healthy lifestyle things that we can do for our hearts and ourselves anyway are relevant here before you have a baby as well.
Okay, just a general one, and I know we talked about movement, Alicia, but this questioner is saying, is it okay to exercise? I'm assuming we're talking about more than movement. They're worried about putting any strain on their heart. Also, does it matter if you're very active before the pregnancy? So if you're already a regular runner, would that make it safer to exercise in pregnancy as opposed to not doing much exercise before? So
generally, we say that unless you're doing things that like put you at risk of coming into contact with another person, an object, falling, we say that it's typically okay for you to continue the activity you were doing pre-pregnancy. But I would always just touch base with your cardiac specialist just to make sure that they're happy for you to continue doing your regular exercise. But we always advocate for exercise during pregnancy. Keep yourself moving because it kind of conditions your body for birth. Giving birth is a very physical, active thing, and the more conditioned your body is, hopefully the easier it will be when it actually comes to giving birth and your recovery actually too.
Okay. An interesting other question around medications. Are dads' medications as well as mums a part of any pre-pregnancy assessment?
Typically no. So there's something called a booking appointment, which is your first ever appointment with a midwife, and it takes about an hour, and they ask you lots and lots and lots of questions. But generally the questions that are asked to partners are very, any history of cancer, any history of diabetes, those kinds of questions. Where you would be asked about your partner's medication history, medical history invasively or more comprehensively would be if you were to see a fertility specialist. That is where you'd be asked those questions.
Okay. One more for you, Abigail. What do you see as the end goal of your research?
So that's a really, really good question. And it's about understanding, as I said, I think I said, how health and disease develop, evolve, what their causes are, what the risk factors are, when the right time, and then by understanding that, by understanding the pathogenesis, the etiology of disease, we can then tailor interventions at the most optimal times across the life course to prevent ultimately the cardiovascular disease event in later life.
Okay, thank you. Two more for you, Becky. Have you made friendships with any mothers who have a heart condition?
I have sort of on the groups that I said, but not physically. I don't think I came into contact with any other mothers that were people that were pregnant with heart conditions at the time. It was quite a lonely time to be pregnant, just coming out of lockdown. But yes, so and your plan is tailored for you, and so I didn't really meet anyone physically, but definitely on Facebook groups. It's nice to sort of see people's journeys, and especially when they have such nice outcomes.
Righty, and a number of people wanted to know this question. How did you come up with the name Dot? It's a beautiful choice.
Well, she was very small.
Oh.
And she still is. So that plays a part of it. But also, I think we had a friend who was a teacher and used to talk about a pupil that they had that was very small called Dot, and it just stuck with us. So that's really how we...
Beautiful, beautiful, lovely choice. But listen, thank you all for your contribution today, and thank you at home for watching this edition of Live and Ticking. We hope you've enjoyed hearing from all of our brilliant speakers. Before we wrap up, I'd like to ask you the poll question again. How would you rate your understanding now of pregnancy and the heart? And as I say, just give you a little moment to fill that in. If we haven't managed to answer your questions today, then we encourage you to visit our Heart Helpline, where you can contact our dedicated clinical team about your query. This is all made possible by you from your generous contributions and support. And if you'd like to make a donation towards our life-saving research, there's a link in the chat box to do so. Live and Ticking is a monthly webinar series, and we strive to produce the best events possible for you, our audience. Your feedback and comments are crucial to help plan and develop future events. So we ask if you can complete the survey at the end of this event or through an email you'll receive in the coming days. This live and ticking event was recorded and will be available on our YouTube channel from next week. Our next event will take place on the 29th of November on the topic of stopping heart attacks. Register using the link in the chat box. Thanks again for joining us, and goodbye.